Evening, everyone. Thank you so much for choosing to spend your, what night is this? Tuesday night with us. We have a fantastic second part of our series that we're doing tonight. We're going to talk about case conceptualization. We have all-star faculty who are here to talk about that. Usually we go through and have the faculty introduce themselves and tell you that they're here. I can promise you that the faculty that are presenting have worked hard. I saw the emails and the PowerPoint and so forth going back and forth. So I don't want to take up any of their time because I think that they can use the whole hour. So I'm just going to ask the faculty to give a two-hand wave real quick. Let everybody know you're here. So scroll through the pages quick, guys. That's your faculty here to support you tonight. And I am actually going to turn it over to Colleen. Who is going to start us off? Which faculty member? Do you remember?
For introductions or the presentation?
Presentation. We're going straight in.
Excellent. I will turn it over to, or we can turn it over to Dr. Colarusso.
Perfect. Dr. Colarusso.
I am here. Dr. Lou, do you have the PowerPoint or do you want me to pull it up?
You can put it up. Yeah.
Okay. Okay. I'm trying to find everyone in this now that my screen is shared. All right, so we are going to talk about today case conceptualization. So Dr. Lou, are you going to start us off with the case conceptualization, or is that Dr. Lip?
I think that's Dr. Lip.
I don't see Dr. Lip. I'll get us started.
Thank you.
Oh, there you go. All right, I can only see 4 and there's 121. So you were lost in the sea of everyone. I will turn it over to Dr. Lip to get us started.
Dr. Colarusso, you are forgiven. And thank you. Thank you. All right. So do I have control of the PowerPoint?
I do. So just let me know what you need.
Yeah. So as you all are aware, case conceptualization is the topic tonight. And case conceptualization, if you could click the next slide. Thank you, Dr. Colarusso. Here's a pretty good definition of what it is. And there's some highlights in there. You see evidence-based practice. And essentially, it's a strategy or a guide to obtain and organize a client's information. And that being said, it's really a roadmap for understanding your clients, their presentation, their patterns, right? And their eventually prognosis. And then that allows you to formulate a treatment plan. And so moving forward, I'd like to just show you something known as an integrative model. There's a variety of case conceptualization models, but this one I like in particular because it's trans-theoretical. You can really use it with any theory you would like, okay? And as you can see, there's 4 components, and these, depending on where you are at in your studies, should be somewhat familiar, right? You have a diagnostic formulation, a clinical formulation, cultural formulation, and then that treatment formulation. And there's also some key elements. And keep in mind, what you see here, this is your full comprehensive, complete case conceptualization. But really, you should be covering those, especially the factors, the predispositions, right? The biological, psychological, and social factors. But again, don't confuse a case conceptualization for a biopsychosocial. They are not synonymous. One is a component of the other. And next slide, yes. And so just to sum up, some of the research shows that identifying, a client's maladaptive patterns through a complete case conceptualization will lead you to form more adaptive ones, right? Change that pattern, that problematic pattern, and make it more adaptive. And so with that, I hand it off.
All right. So Dr. Lip did a really good job of kind of setting the building block of what is a case conceptualization, right? And all of you are at very different points in the program. Some of you might be in your very first term. Some of you might be an internship too. And so those of you, and I see a lot of you that are in fieldwork, so you have seen this before because we use this in fieldwork. But kind of looking at the case conceptualization template. And so how I like to look at a case conceptualization is kind of like how Dr. Lip talked about it, which is, you know, a lot of these classes you're building, it's a building block, right? It's a building the knowledge to be able to understand how am I going to get to the point where I can do this in front of a really good group of clinical staff, psychologists, nurses, clinical directors, therapists, right? And every agency or every place that you work does these a little bit differently, but this is the main meat and potatoes, I guess, of case conceptualizations. So I'm just going to go over what we look for in fieldwork, so specifically, and then I'm going to hand it over to Dr. Lip or Dr. Troutman. So first of all is the introduction to the client. And so this is a lot of what we view, this is our perspective, right? So this is a mix of information that the client is giving us and how they're presenting versus how we're observing this client, how we feel about this client. What are we seeing about this client? So some of the things are very basic, right? Straightforward demographics. So that's gender, age, ethnicity, career. What's their job like? Do they have any legal issues? What's their career history? Mental status exam. What is their appearance? Are they, is their clothes appropriate for the weather? What do they look like? What's their appearance? How do we get this information? Did we look at it through an interview? Did we use a specific tool? There are different tools for mental status exams that we can use. Agencies usually have different ones. But here's some examples below of kind of what we're looking at and what we want to get to, right? Do they have any psychotic symptoms? Is their thought process clear? Is it cohesive? Or is it very tangential? Is their mood appropriate? Do they feel maybe depressed or euthymic or happy? Or are they really guarded? What are you getting? Like, what are you sensing from this client? And usually this is the first thing that we go over because this is the first kind of initial impression that you get from a client. So this is really what we feel or what we're looking at or how we're observing the client. The second part of a case conceptualization is the presenting problem. So it's why are they here? Why are they in front of you? Why are they here? Why are they coming to see you? This looks very different depending on every setting that we will all work in. And it's also based off of the client's perception. Because again, a case conceptualization is a lot of client information, self-report, who referred them? Again, how did they get here? And so sometimes we might, be handed a little piece of paper that says a lot of this information, but we really need it from the client. We really need to understand where the client is coming from, what their perception is, how do they see why they were referred, right? Who referred them? Where did they come from? What is the client saying in their own words? Why are they here? We can say why we feel like the client's here, but why are they here? Why do they feel like the client is here? What's a description provided by others involved in the client's life? So an example of this would be if someone's significant other or partner came to the session and they said, well, that's part of it, but this is the other part, right? So again, your job is to kind of gather as much information as possible around why the client is here. What has the client been doing? What kind of symptoms or what kind of stressors or precipitating events led up to what got them here, right? And again, here could be inpatient, here could be outpatient, here could be a crisis center, substance abuse facility, detox, right? Any level of care that we would all work in. So you want to be able to understand what brought them here, and then also what led them to get to this point. So this is a really, really, really detailed snapshot. And sometimes the most difficult part is we're gathering all this information, and sometimes we only have like an hour to do it. So assessments and case conceptualizations, in my opinion, are really an art form. You really have to learn not only how you get this information, but how to get it really well and share it really well. Are there any recent life changes? Again, you want to just kind of get exactly where they are, maybe in the last week or two, to get them why they came from here. We don't necessarily need to know what happened 20 years ago. And when, what is the expectation of is the client's expectation of treatment? Do they want to be there? Are they really looking for a specific type of therapy or intervention? What are their expectations? Past personal history. So this is kind of a brief, again, a very brief snapshot of where they came from, right? So we're kind of looking at their life story, childhood, adolescence, adulthood. Again, this is going to be dependent on the client's age, but what happened within these areas? What was their childhood like? What was their adolescence like? What were their parents like? Where did they live? Did they have any significant life events as they were growing up? Birth order is one thing that I always like to know. High school or highest level of education, what does that look like? All of these areas give us those. How I also like to think about this is all of these things are like Post-it notes in our head, right? So we might not need to address it right now, but sometimes I'll think like when I'm working with a client, or I'm doing an assessment, or I'm doing a case conceptualization, it's looking at what are the most important highlighted Post-it notes that I need to pull out of here, because some are really important and some might not be that important, but we don't know until we kind of get to the end and look at everything as the big picture. Social and environmental. So this is the current systemic assessment. So this is what is right now. What is happening in the moment? What is happening immediately in their life currently? What is outside if they need anything? What are their supports? So looking at their current social and environmental situation, kind of those social determinants of health. So like the financial, the cultural, the spiritual, legal, relational, family structure. Sometimes it's really helpful if we do like a genogram, right? To kind of help for us to conceptualize and for you to conceptualize what is their family life like. Stage of life cycle, family life cycle. So kind of conceptualizing Erickson stages or maybe Piaget stages. What is their source of income? Where are their stressors, right? So also think of like Maslow's hierarchy of needs here. Is the person able to kind of meet their basic needs to then be able to work ahead? Or is that where we need to start? Do we need to connect them to resources? What does that look like? Any medical issues? This is really important because even though we're not necessarily prescribing medications, we do need to know what medications they're on, because generally this case conceptualization is seen by a lot of different people in the client's level of care or their treatment plan. So like the nurse would see this, the psychiatrist would see this, their medical doctor might see it. And it's really a good place to kind of have them get started. So we understand what medical issues they have going on. How might the medical issues impact the psychological or the mental health impacts? Did they have recent surgery? Do they have a chronic health concern? Things like that. Really important to talk about sleep and diet and exercise, and what does that look like in their life? Is it a part of their life? Is it a big part? Is it a small part? Do they want it to be a part of their life? So really kind of getting a really good picture of what does this look like for the client. And again, every agency that you work with generally have a different way to kind of go about obtaining a case conceptualization. But one of the things, like Dr. Lipp mentioned, is we don't want to get this confused with a mental status exam. So a case conceptualization is kind of how we learn how to collect and present information about a client. So it's not necessarily a specific form, but it's more of, you know, sometimes when you're in field work or you're working in an agency, your site supervisor might say, okay, Michelle, like I need you to do a case conceptualization of, you know, this client, because it seems like you're, you know, this might be a client that we're talking about more frequently. And we have to kind of come up with, okay, let's look at the big picture of this client. So sometimes whenever you feel stuck with a client, case conceptualizations are a really great way to get feedback from peers or get feedback in supervision, because it helps us to kind of see like, well, what parts am I missing, right? Or, you know, allow peers to say, hey, you know, you never really talked about, you know, they had a heart attack recently. I wonder if that's playing in anything into their mood, right? So sometimes it's kind of picking up on things that we don't always think about, as sometimes we get stuck, right? It's helpful to get a bigger picture and get a broader picture. So case conceptualizations, we want to be thorough, but they're also really used as a tool to kind of best help the client. So it's not necessarily a tool that we use to kind of give feedback on how we're working with the client, but sometimes just other providers or other treatment team members' perspectives on, you know, what does this client look like? So if I was giving a case conceptualization on, you know, my client, and Dr. Troutman and Dr. Liu and Dr. Lipp were in my treatment team, the goal of this case conceptualization were for me to be presenting all this information and for all of them to give feedback on, you know what, I feel like I'm curious about this. I'm wondering about this. I'm wondering if you worked with this. I'm wondering if you thought about that. And that gives me a really, really, really good picture of where else didn't I think about with this client? Where else could I go with this client? The next thing is mental health. So this is really important to kind of get current and past diagnosis. One of the things that's really difficult is because sometimes we don't always have like the records for where the client has gone if they've sought treatment before. So sometimes the diagnoses are more like self-report. And sometimes that's helpful to get an idea. And then sometimes, you know, the clients will give you a diagnosis that may or may not be correct. So you also have to keep that in mind. Have they sought treatment before? Have they ever been inpatient before? Was it recently? Have they been outpatient? Have they been in substance abuse treatment, detox? Are they currently using? We'll talk about substance abuse in a little bit. Are they on any medications? How many medications? Where are they with their prescription? Do they have enough left? Are there any safety plans involved? Do they have any crisis plans or emotional safety plans? Are you concerned? Are their family concerned, or are they concerned with any impulsivity or suicidal thoughts? And we have to make sure that we know the details, right? So if you know, if the client comes in and says, yeah, like I've had suicidal thoughts in the past, but I haven't had any recently, what is the past and what is recently, right? So we want to make sure that we're asking we're getting the details on the questions around specifics regarding their treatment, because that really, you know, someone being an inpatient 1 week ago is much different than someone being in there a year ago or 5 years ago. So we want to make sure that we have as much detail and information as possible. How long that they've been on the medication is really important. If they said, you know, I got this medication prescribed yesterday and I just started taking it, well, then we know it's not necessarily, it might not be effective yet. So just kind of us being able to put together the pieces of what that looks like. And the last thing for mental health is emotional health. So how are they feeling? What is their self-esteem? What are they thinking? What are they feeling? What are their behaviors like? Are there any mood disorders? Are there any anxiety or depression? Is their diagnosis relevant to that? Did the client say, oh, I'm really anxious, but you're getting you're getting this thing, the feeling that something is different, right? And that's, again, this is where you're starting to kind of put everything together. Follow the cues that the client gives you is so important. You know, even though they say one thing, it's still our job to kind of think outside the box. Even if we come back to, yes, that client was right, and this is where I agree with, you know, always be curious as to what kind of is, what the client's feeling or what they're thinking. Before I go on, does anyone have any questions? I haven't really been following in the chat, or anything else Dr. Troutman, Dr. Lip, or Dr. Liu want to share?
Dr. Kohler, so I just repasted a question that was entered a little bit ago.
Oh, thank you. In my experience, some of the challenges are just if the client is, if their mental health symptoms are acute, it makes it really hard to gather information. If they're court ordered and they really don't want to be there, it's really hard to gather information. So I think it really depends on the client. As far as gathering information, you kind of just have to gather what you can, right? There's never going to be a time where you leave meeting with someone and feel like, I think I got everything I needed, right? Because they forget, clients forget to say things. You know, imagine all of us, I can imagine everyone on this call has gone to some kind of doctor's appointment and left there and being like, oh my gosh, I forgot to tell them about this, right? And so again, it's our job to kind of prompt and think about, you know, what else could we ask? But this is why, like, going over this case conceptualization and having kind of a form to kind of check boxes is make sure that you hit all of those big categories is really important, right? Because sometimes, and addressing them, right? So you might work with a client and be like, do you have any past medical history? And they might be no, but you still want to document that, right? Even if the answer is no, I don't have any past medical history, you still want to document that. So just because a client says, no, this doesn't apply to me, doesn't mean it's just off the table. You still address that, you still document it.
I can add to that, Dr. Colors,
Go ahead.
because a lot of times clients don't know what's relevant.
Mhm.
So they're not going to tell you what you need to hear. They're going to tell you what you think that you want to hear. And what I've always explained to clients is like, don't leave anything out, because you might think that that medical diagnosis or that time at the ER or whatever was insignificant, or the way that you had a fight with your mother-in-law or your partner was insignificant. You need to include that with what you're saying, because from my perspective, it can be very significant as someone who does not know you as a third party looking in. So just sometimes our clients don't know what's relevant, but they're trying to play to us and trying to give us what they think that we need. So it's very important to kind of go back and kind of loop back around and say, well, let's look at this a little bit further and tell me a little bit more about this, and tell me a little bit more about the absence of any medical issues and things like that. Tell me about that. Oh, well, I didn't think this was important. Oh, okay, well, let's talk about that. So always think about how to go further and try to draw that narrative out a little bit more.
One of the things that I would always see too is clients would not always ask about, one of the things they wouldn't ask about is like relationships or intimate partner violence, or, you know, what relationships look like with family members. And that's one of the things that when I would do case conceptualizations and intakes, that was one of the challenging parts was, you know, you would say like, let's talk about like, you know, what are your relationships like? Oh, well, they're fine. And then you would say, okay, well, you know, tell me about your partner. What's your relationship like? Are there any, is there any concerns with domestic violence? And so sometimes it's, you know, when you ask those really broad, open-ended questions, they don't give you as much. But when you say, okay, well, tell me about your relationship, if they don't want to share it, then you say, okay, well, tell me about your relationship. Is there any history of abuse in any relationships that you've been in? Name the specific types of abuse, right? So then they're more willing to say, okay, well, you know, that the clinician brought it up, I can share, kind of like what Dr. Troutman was saying. Clients don't necessarily, they're not withholding information sometimes. Some clients do. But it's more of just they don't know really what to say or what to ask.
When they say that, yeah, my relationships are fine, well, tell me what fine is. Tell me what fine looks like for you, right? Because we have an idea of fine. Like my relationship, I know what fine looks like for me. If Dr. Colarusso were assessing me, her definition of fine might be very different than my definition of fine. And that's the information that we need to know. We need to make sure that we're clear on our client's vocabulary.
We talked a little bit about substance abuse, but really this is really, really important, especially if the client talks about recent use. I'll give you this example, and it kind of shows how important this is. I was doing a case conceptualization. I was doing an intake with a client, and he immediately said, oh yeah, he was just out of detox. And then he started using alcohol again. And I asked him like, okay, have you been using? Yes. How much have you been using? Gave him a scale of like, okay, did you have like 1 drink or did you have like 6/5 of alcohol? Right. And he said a really high amount. And the first thing that I was thinking about was, okay, this person could go into post-acute withdrawal symptoms, right? This person is a really high chance of going into withdrawal. So I went, he was in there with his caseworker. I went out to get the nurse and I was like, hey, this person, I'm like concerned about this person. And from the time that I left the room until the time that I got the nurse, he was already starting to like have a seizure. And we had to call 911 and he had to go to the hospital. But it can happen really quickly. And so kind of like what Dr. Troutman was saying, we really need to understand what is their vocabulary? What is yesterday? How much did they have? Well, I didn't really have that much. Their not as much might be different than my not as much, right? So it's really, really important to understand and for us to know, okay, like 5/5 of alcohol is a lot. 1 bag of heroin isn't that much, but maybe 20 bags is, right? So we need to understand the language to be able to understand, okay, well, what is a lot? You know, what am I concerned about with this person? And do I need to kind of seek medical treatment for this person if I am really concerned? If they're discharging or if they're going back home, we kind of talked about their living situation, but when it comes to substance abuse, do they live around family members that are supportive, or are they living around people that they use with, right? What's that environment like? Do they have a job? Do they have, again, the financial consequences? Where are they currently living? How much money do they have to continue to pay their bills if financial concerns if financials are a concern? So there's a lot that goes into substance abuse, specifically if the client has that. And again, we always want to ask, and if the client says, no, this isn't a concern, ask a little bit more about that, but then still jot that down to make sure that we addressed it. Client strength and resources, pretty self-explanatory. Again, this is your overall assessment of the case, just kind of what we talked about before. Last 2 things are the diagnosis. So we will give the client a diagnosis, but we want to be able to think about the diagnosis is different from the case conceptualization, right? So the diagnosis describes the client's needs, and understanding the client's needs is the case conceptualization. I just kind of like to put those the differentiations in there. All right, I'm going to pass it over to Dr. Liu.
Thank you, Dr. Colarusso. So the next thing I want to talk about is conceptualization or conceptual orientation. So Dr. Colarusso was talking about all the data points that we are collecting, all the information that we are going to get from our clients to understand where they are and what do we have, right? So let's put your counselor's hat aside for a moment, and just as a person, how do people conceptualize a story? So we have the story itself. So the story could be a book that I read, a podcast that I listen to, a movie that I just watched, or a story or my childhood story that my parents told me just recently, right? So all of those are story itself. And then we have the receiving framework, which is how we receive those information. So that based on our own experience. So when I hear this podcast or when I watch this movie, let's say I watch the movie that about loss, and I lost someone that I love recently. So that's gonna significantly impact, and I will be significantly relate to because of my experience. And also it's based on my worldview, right? Does that align with my worldview, or does that contradict with my worldview, or how somehow challenge my worldview? So that goes on same as our culture and the traditions. So when those things are aligned, we are more likely to be engaged with that story and continue to be engaged with that story. And when are challenged with those worldview or culture traditions or the story itself, some people will likely say, no, I don't want to hear it. I don't want to hear that story. It's not for me. I don't want to watch it anymore. And some people will be really curious and say, hey, that's interesting. I wanted to know more about it. And also I want to begin encourage you to thinking about even the same story, same movie, and same podcast. 10 years ago when I listened to it or when I watch it, it's going to be very differently than what I watch when I watch it now. So it really depends on where we are personally, how we're receiving those stories. So how we conceptualize the story. So we have a story itself. We have the receiving framework that based on my experience, my worldview, my culture and tradition, and that leads to our own understanding. So for instance, give you another example, the same story told in your family, right? And the siblings will remember it completely differently, or they will perceive it completely differently. It's just because the story itself has its content, but also the receiving framework makes its own understanding and meaning. So this is how we, as a person, typically conceptualize the story or understanding a story. Dr. Chlorophil, do you mind to go to the next stage? Then how do counselors conceptualize the case? And I wanted you to thinking about in the same framework, we have the case itself. So that including all the presenting evidence that Dr. Chlorophil just talked about, the diagnosis, the resources, the strength, the system, all of those medical issues, history, all of those are presenting evidence. And then we have this narrative stories from our client. So I am a narrative therapist. I'm a social constructionist therapist. So what I focus on is how the client tells the story, the tone, the language, the way they describe their experience tells me a lot more information than the story itself or the case itself. So we have the case, including all the presenting evidence and also how this client is telling the story. Then we also have this receiving framework. So that receiving framework as a counselor, it looks like our clinical experience and expertise. So our experience could be some similar cases that I worked with before. It could be if I'm a trauma-informed counselor. Oh, still the previous slide, Dr. Chlorophil. Thank you. And it could be trauma-informed training that I had an expertise, and I'm a systemic therapist. So I'm looking at things from a systemic perspective and thinking about relational, all those issues and all those challenges individual experience somehow are relational. So that is how I view a case, is based on that clinical experience and expertise. And then also based on our theoretical orientation, like I keep saying, I'm a narrative therapist. So I'm looking for those language, those storyline, how the story is being told. Just like I'm presenting this presentation itself right now, what I'm trying to do is trying to find a storyline. So my audience can follow my storyline and understand the information in a very simple way, right? So that is your own theoretical orientation. So if you're a CBT therapist, what you're hearing is going to hear a lot of cognitions. It's a lot of irrational thoughts and beliefs. And then you are going to listen to how those irrational thoughts and beliefs lead to their maladaptive behaviors or challenging behaviors. So that's how CBT therapists will hear and inform their understanding of the case. And also that based on the client's unique culture and dimensions, and Dr. Trotman will talk about it later on, is that we have to really understanding where my client is. So for instance, if you and me sitting in the same room, looking out the window, we're gonna look at something really similar because from the same window, but there are going to be differences because I am not sitting in the position where you're sitting. So as a counselor, we needed to put ourselves somehow sitting where they at, their cultural dimensions, their understanding and their where they are in life, and then to see what they see outside of the window. So that's where we have to do to conceptualize the case in the way. So what I thinking about conceptualization or case conceptualization and treatment plan is just part of that case conceptualization is a gift with a therapeutic intention. So what that means is I have a daughter. So she was born in December 24th, the day before Christmas, great day. But what the challenge comes for us is that we have to separate her gift. So her birthday gift needed to wrap with a birthday theme wrapping, and then Christmas gift needed to decorate it with a Christmas theme and Christmas wrapping. So what that means is we put our awareness and intention in terms of how we deliver this gift to my daughter. So similarly, when the client gave me a gift, which is their story and their experience that they share with me, a stranger, and I feel like that's all our privilege to have that gift. So how I am going to wrap this gift with the intention and with the details specifically for this client and then give it back to them. So that is a gift with a therapeutic intention that what that case conceptualization is all about. Dr. Clarissa, do you mind to go to the next? So at the same time, we have to know that I cannot just always wear my counselor's hat and just ignore the person part of it. How do we, both as a person and as a counselor, to understand and support clients' challenges? Because at times I have to ignore the personal side of it or put that aside. But sometimes that side actually goes to benefit for me as a counselor in the room when I'm talking to my clients. So the first thing is to be aware of the existence of those two roles. If we're not aware, especially if they are in conflict, if we're not aware of them, then we are doing something that is, again, without that intention and without that awareness. So for instance, if I have a client comes in and talks about her challenges with her daughter-in-law, like Dr. Trotman's example earlier on, a daughter-in-law case, right? And I'm hearing that story as a person or as a daughter-in-law myself, I will be like, God, that sounds just like my mother-in-law, right? But when I'm hearing from a counselor's perspective, I will hear this individual's pain and the suffering, and then the experience that they had, how that traumatically impacts them. So I have to be aware those two roles are existent in one person, which is Victoria, right? Then I have to understand how I sometimes take me outside of that case. So if I'm hearing from a person's perspective, then I will respond to this case as, okay, this is another mother-in-law. I can't believe what she said, just like my mother-in-law, right? But if I'm putting myself in that case, then the way I conceptualize this case and the way I construct with interventions later on when it comes to treatment plan will be significantly impacted by this role. So I have to take myself out of the case and keep telling myself, this is not my mother-in-law. She's not talking about me, right? So those are skills that we have to take us out of that case as well. But also at the same time, like I said before, we're also a person. Some of our personal experience will help in this case. So for instance, in this example, I might using some challenging questions or curiosity to help my client to think from a different angle and different perspective and see if that's something she has ever thought about, right? So I have to using those two roles in a way that best fits for my client. So the third thing is what is the best option fits best for this client, right? So if I take the role as a person or as a daughter-in-law solely, then I'd be like, just do X, Y, Z, your daughter-in-law will thank you, right? Because that's how my experience is. But that might not best for this client. So I have to thinking about from a counselor's role of based on those interventions, based on those theoretical orientations and those expertise and training, what is best for this client. And then finally, I needed to finalize it with my client. I can't just tell my client, this is what I think of you, this is what you needed to do, and have a good life. I have to finalize it and construct this whole thing with my client so we are on the same page. So recently I have a client told me that, you're the first client for all those years she had a counselor that has first time talked about treatment plan with her. And I'm thinking, treatment plan is something that we have always shared with our clients along the way, because the treatment plan and then the way we conceptualize, it might change. It's a fluid. It's not set on stone. And we have to always finalize it with our clients as we go. So that's part of me, and I will hand over to Dr. Shortman. Or Dr. Colorado.
Sorry, I couldn't hit the unmute button fast enough.
That's
So, okay, so diversity considerations. Please understand that the bullet points that you see here are just a selection. If I were to go over every bullet point that made us different from one another, this would be several slides long. So I just picked out 6 of them that I wanted to highlight today. Of course, there will be a lot more that you can think about as you're considering conceptualizing your client. You can go to the next slide, Dr. Colorado. Now, nationality and ethnicity are sometimes used interchangeably, but not so much now. Instead, when we think about nationality, think about it more as a person's citizenship. And that's just kind of like where they're from. We need to think a little bit about what are their cultural norms? What are we actually seeing in this individual? And that kind of leads us to salience. Like, how salient is this for the individual, right? So if we experience an immigrant from another country, we may default to, well, this must be really salient for you. This must be really relevant for you. And that's not always the case. And it's having that discussion with them. Oh, we're flipping slides. Okay. And it's having that discussion with them to see that how salient is this for them? Because we need to make sure that we're not putting too much of ourselves onto them, right? We need to make sure that our lenses are not overpowering their experience, which leads us to this whole idea of ethnocentrism. We also need to think of our clients, but take ourselves out of that a little bit. We have a tendency to view our clients in a very Western, American, middle-class way of looking at them. And that's not always the case. But it's by having these discussions and clarifying that vocabulary that we begin to move outside of this realm of ethnocentrism and really understand the client for who they are, which then bleeds right on into cultural relativism. We need to think about our clients' behaviors and our clients' manifestation of symptoms as very relative to their culture. So if we think about how we express grief, this is expressed very differently in some Middle Eastern countries. It is very visual, it is very vocal, it is very physical. That is not how we express grief in this country. So we can't say that, wow, they're reacting a little bit extreme, so that must be an indication of something. No, that is indicative of their culture. So think about how we see them through a lens that's not necessarily our lens, but we're actually borrowing from their lens. We're borrowing from their cultural way of seeing things. Now, there are processes that affect ethnicity. There's this whole concept of enculturation and acculturation, right? So enculturation is kind of how folks who are outside the dominant culture begin to learn how to live here. Acculturation is kind of like how we do a mixture of the same. It's kind of like assimilation versus acculturation as well. Do you assimilate into your host environment now and totally wash everything away from you? Or do you actually keep components of you? And that can really impact behavior, the values you have, the knowledge they possess, and their own cultural identity. Like for some folks, it's not safe to be a Mexican American in America and in some spaces and places. We need to understand that about our client and understand that this can also add to the manifestation of some of their symptomology. And there's also possessing a little bit of cultural humility as a clinician. We won't know everything about everybody. And I'll say that again, we won't know everything about everybody, and that's okay. That's totally okay, but we have to also lean into this fact that we're gonna learn it though. We're gonna ask these questions, and we're not gonna bring any assumptions into the room. We wanna know about the cultures that we don't know about. We wanna know how this manifests, and that's that humility, that cultural humility of wanting to learn about another culture. We're not going to suppose that, oh, well, we've seen this here. We've read a book. I read a chapter in the multicultural text. We can't really assume that then we know everything there is to know. We have to actually experience that client as we build their conceptualization. You can go to the next slide, Dr. Collerson. So race, this is very indicative to our country. It's a very abstract concept. Again, very indicative to our country. And to be explicitly clear, there is no such thing as race. It's really an arbitrary classification that we try to categorize people of common ancestry, like with physical characteristics, hair texture, eye color, skin, stature, etc. In and of itself, it's just the belief that one is superior over someone else. And when we look at how society was built in the 50s and the 60s, hell, even in the 30s, it's like we need a way to classify people. We need a way to kind of make this one ahead of this one, or to group these people together. It's a sociocultural construction that is very unique to our country. And when we think about racism, it doesn't always need to be obvious. So we need to understand how our clients are experiencing this. And these are what these microaggressions. And we categorize these with micro assaults, micro insults, and micro invalidations. These are very, very subtle ways that folks seek to denigrate other people. It's not as obvious and like, whoa, you need to calm down. It's more like, did I hear that right? So you're not really sure how to respond to that. And as a person of color, you're not really sure what to do about that. Because in some spaces and places, it's like, I'm going to react to that. But can you react to that the same that someone of the dominant culture can? No, you probably can't. So how is this manifesting for the client that you're conceptualizing? How are they experiencing the world? And familiarizing yourself with a lot of the identity development models will really help you. And unfortunately, it's beyond the scope of what we're doing here, but kind of like really researching those identity development models and figuring out, does my client fit in here? If they don't fit in, how do they deviate? How can I apply this to them, if at all? Are they totally outside of what this theoretical orientation has told me about where they are and how they develop that identity? And of course, just asking the questions and really grounding ourselves in cultural humility. Go to the next slide, Dr. Collerson. So social class, we hear a lot about this in our country, but I don't think we're really clear about what this looks like and how this manifests. So we have socioeconomic status, which is a little bit different than actually your social class. So social class is a little bit more subjective, and it usually indicates people's perceptions about a group. And it really indicates assumptions, rules, and hidden meanings that's shared among people of particular classes. There's also objective definitions of class. So it's just ways to, again, divide us and to kind of put us in these categories again. And if we see the illustration over there to your right, you kind of see how this is constructed and where the majority of people are. But we need to understand how people are actually experiencing this. And as we layer on top of that is, how are people experiencing classism, right? How are they actually being treated by that manager? How are they being treated by that privileged dominant person in a higher income bracket? What's that like for them? What's it like for a trade worker to go into a higher end, upper class environment or neighborhood to do work? How are they treated? How do they experience that? You know, and how does that kind of permeate into the way that they experience the world around them? How do they experience their quality world? And we don't really talk about this a lot or enough, because again, we're kind of apprehensive to talk about money and where we are socially and societally. We don't want to talk about these things because we've been labeled that it's taboo, right? We can't talk about those things. We shouldn't talk about those things. We should absolutely talk about those things because they are components of how we experience the world. And as we think about that, poverty is a very ubiquitous thing, but it can be a very hard thing to wrap your head around. And it can be a hard thing to understand situational versus generational poverty. So if we have situational poverty, we're thinking about maybe an individual who was in a partnered relationship, children, and this person was a stay-at-home caregiver. Well, upon the divorce, they didn't have a job. So now it's just them and their children. So in that aspect, we're dealing with situational poverty. Sometimes it's temporary and sometimes it's temporary to permanent. But what does that look like for them? How do they experience it? And next door to that is the whole idea of generational poverty. This is where poverty has been passed down through the generations. Like, we've always been here. We're always going to do this. And when we think about generational poverty, there's almost like a vector for that as well. It's like, this is who we are. This is who we are. This is who you're going to be. And this is what your expectation is to be. And as soon as you start to deviate from that, you begin to get this whole rejection from your family of origin. So do we have somebody who's a first generation college student who's moving beyond their families of origin? What does that look like for them? How does that feel for them? So as we're assessing and thinking about interventions, it's really being aware of ourselves as well. How are we sitting here with our privileged middle class lenses, looking at this individual? How are we experiencing them? Wilber's integrative model is a really good model to assess for kind of like how class permeates and how we understand that. You can go to the next slide, Dr. Cullerson.
Dr. Troutman, I'm sorry to interject. However, we have about 4 minutes left. So if anyone, I want to be respectful of time. If anyone does need to jump off, this is going to go a little bit over. Please feel free. We will be posting the whole recording on our YouTube page, and the link will be posted in the announcements where you found the information for tonight. So just an FYI.
Thank you, Colleen. The more you know. I love it. So as we continue thinking about social class, there are certain assumptions that can be made, and understanding how folks that are in poverty, the middle class, and wealth actually see things. I'm not going to go through each one of these. When we post a recording, you can look at them. But even just think about money. You know, how do folks in poverty understand money? You know, it's to be used and spent. So the middle class thinks that it needs to be managed. And for the wealthy, it needs to be conserved or invested. So how do they actually interact with these things? How do they actually experience these things? And each one of those things, and this is a really good actually book by Ruby Payne, are the hidden rules of social class, because it was really bizarre. When I started reading this, I'm like, oh, well, now this makes sense, because we see it manifest every day. We just didn't know where it was coming from. So it would really behoove you to think about what are some of the ways that folks have been acculturated, or folks have been socialized to think about certain things: education, language, destiny, love, all of those things. How have they been acculturated for that? And we can also assess, do our clients actually match with this or not? Because we don't want to make any assumptions about them either. You can do the next slide, Dr. Cullerson. So gender identity and expression, yeah, that is a super loud topic right now. Super loud topic, and our community is under attack right now. And I'll be honest with you, I'll be very transparent. Our community is under attack. We thought that we were cool after the Obergefell case. We thought we were cool after certain things. No, we're not. The United States folks still need another target. And right now, the LGBTQIA+ community is their target right now. But we need to understand the difference between sex and gender. What does this look like? Sex and gender are typically used interchangeably by folks who don't know. But to be clear, sex is more of a biological categorization, something that's been assigned at birth. Gender, on the other hand, is something that's outwardly seen in how one presents. So we need to also understand gender socialization. How have folks been taught to understand their gender? Have they been raised in a super uber masculine household where this is how you're supposed to behave as a masculine male? Or have they been like taught as a female to be very subservient? Like, how are they experiencing their gender? And of course, this is very fluid at the moment because our society is dealing with gender in a very fluid manner right now. And there's also this whole idea of gender stereotyping. Since you were assigned male at birth, therefore you should do these things. That's not always the case, but the pressure still remains the same. And are they experiencing that pressure? And as we think about gender and assessment, it's less about looking at the person for who they are and more understanding who they want to be and how they're presenting. Because the person in front of us might be very different than the person they believe themselves to be. Next slide, Dr. Alderson. So with affectional orientation, we need to be very aware of ourselves when we're thinking about affectional orientation. How are we actually being reactive to this? Are we open? Are we curious? Do we already have some biases? What those biases look like? Because all of our biases are going to color all of what we're doing. It's going to color every single part of the client conceptualization process. And to think that we don't have biases, you haven't been through the multicultural class yet, because we all have them, but it's learning how to manage them and learning to understand them and how they pop up and how they impact our clients and conceptualization is most important. There's this whole idea of heterosexism, seeing the world through the lens of only heterosexuality is appropriate. Only this is the way to look at things. And it's pervasive. And while we thought that we had transcended to a more pluralistic society, we are sliding very quickly back into a heterosexist way of looking at things. And as counselors and emerging counselors, it's important to understand that with our view towards social justice, we have to impact this. We have to disrupt this trend. That is what we're going to do. There's also cultural specific challenges as it pertains to affectional orientation. There's problematic coping skills. There's a coming out process, systemic issues, like are they like ensconced in a very cultural bubble? And there's also this whole intersection of affectional orientation and ethnicity. It's like, how do these two things like collide? What is your identity? What is your dominant identity at a particular point in time? There's also the experience of reparative and conversion therapy. Have folks been through that? What's been their experience? And understanding that folks don't come out of that very well most of the time, and understand that is completely inappropriate. And again, understanding our own biases as it pertains to that. You can go to the next slide. As we're flying through this. And as we think about diagnostic implications, please understand that we're going to have a class bias. We also have to understand that we have to transcend that bias. There's also going to be a gender bias and a racial ethnic bias. We are programmed to diagnose folks who are different from us, who are in the minority with more severe mental health issues than those who are of the dominant culture. That's what research tells us. I'm not making this up and telling you. That's what research tells us. We tend to diagnose those who are not of our primary culture more harshly as well, to say they have something more serious than they do, because again, we go back in this cultural relativism or this ethnocentric way of looking at things, and we say, oh, well, they are this and they're expressing this, so therefore this is problematic, this is maladaptive. So we have to really ground ourselves in culturally sensitive diagnosis and thinking about how culture actually plays into this and the salience of that, and recognizing some of the cultural terms for mental distress, you know, and maybe actually coming alongside of some healers and folks who are in that culture. And you really utilizing the DSM with cultural alertness. We have to remember where the DSM comes from, how it was created, and how it's being applied. So yeah, those are just my thoughts on diversity considerations and conceptualization. And yeah, whoever wants to take treatment plan and prognosis.
I can do these. So Dr. Liu kind of talked about treatment planning, so I'm not going to go over it too much. But being able to kind of determine short-term goals and long-term goals, what referrals or what other services the client might be beneficial for, whether it's medication, whether it's, again, depending on your level of care, where you're working. Is there anything that requires immediate action? So any of those mandated reporting issues, is the client suicidal? Are they homicidal? Is there any concerns that are presented during the case conceptualization or the treatment planning process? What are the client's goals? What are our goals for the client? And kind of coming up with a good plan for both. And then what is the prognosis? What do we think the treatment goals, the process for treatment looks like for the client? Is the prognosis good? Is it not really that great? What are the barriers? But we also want to talk about the client's strengths, their supports, things that they have going for them, but then also some of the barriers to treatment and barriers to successfully completing treatment. And that's it. We appreciate you being with us today. Thanks for sticking around 5 extra minutes.
Thank you all.